The session is titled Data-Driven Vaccination Strategy for a COVID-Free World. As you all know that the ongoing pandemic had a profound impact on the data landscape. And this was possibly most visible in case of articulation of the vaccination strategies in different countries. And we all know that the vaccination strategy or effective implementation of the vaccination strategy would be one of the cornerstones of the post-pandemic recovery programs. Our review has shown that wide-ranging countries have undertaken different innovative data initiatives during this pandemic in order to define, design, and deliver their vaccination strategy. Today in this session, we are going to put forward a comparative perspective on different types of vaccination strategies pursued in different countries of the world, 4 presentations from 4 different continents of countries at 4 different levels of economic and social and environmental development and facing different types of challenges. So before we get into the discussion per se, we would like to introduce you to the results of an online survey which we conducted during the last 3 days. And the results will essentially give us a good background to pursue our discussions in the next hour or so. So let me invite my colleague, Mr. Tawfiqul Islam Khan from Center for Policy Dialogue, Dhaka, to introduce the study results or the survey results in the next couple of minutes. Tawfiq.
Thank you very much. We conducted this survey among the participants of World Data Forum using online platform. We asked 5 questions to them. Our first question was that we wanted to know that did the data system in our country adequately support the vaccination drive? And we have found that 57% agreed that yes, it was supportive, and 35% said no, it was not. 8% did not say any response. We also asked them whether civic registry was a binding constraint in terms of providing vaccination to the citizens of these countries. 48% said yes. Again, our considerable portion, 32%, said no. We also asked people that whether an online pre-registration helped vaccination strategy in the context of your country, whether it is developing country or a developed country. And we have seen that overwhelmingly 71% said that online-based pre-registration was an effective vaccination strategy in the context. We also asked them whether the marginalized community, considering their location, ethnicity, gender, age, did they receive an equal opportunity as regards vaccination. And we have seen that 64% agreed that marginalized communities were also included in the vaccination system equally to the mainstream population, and 34% disagreed. Our last question was, in your country, do you have citizens' age-related central database with the authority by location for framing a vaccination strategy? And 55% said yes, it was done. So we wanted to know what kind of data actually helped vaccination strategies both in developing countries and developed countries. And we have seen, surprisingly, is that online pre-registration was very important. And the data, citizens-related data, including age and location, was also quite effective. We also have a few flyers lying around in the room, and people, my colleagues will be sending you the online poll link with you. You can also join here. We can use this poll to consolidate our findings and come out with a piece with a summary of the discussion and the online results later on. Thank you very much.
Thank you, Tawfiq, for that. Dear participants and colleagues, friends, you have just heard the results of an online poll which we conducted during the last 3 days. amongst the participants of the UN Data Forum. And the results are very encouraging, although there are some mixed undertones. So the data initiatives have been quite important in the COVID period. The importance of the civil registry has been underscored. The online registration, prior registration for vaccination has been highly appreciated. And it seems that the marginalized communities have been included up to a point in various degrees in different countries. And the 8 location-specific data had been used in many countries for this vaccination strategy. Thank you very much. That gives us a bit of an idea, a cross-country, cross-thematic perspective about the data situation in the vaccination process in different countries. Colleagues, do we have Dr. Agnes with us already? Has she joined?
Yes, sir, we do. She's here.
Yes, I'm here.
Oh, excellent. It's my pleasure now to open the panel. And we are very pleased that we are opening the panel with no less than a person from Rwanda with global acclaim. Dr. Agnes Binagwaho is the former health minister and currently the Honorable Vice Chancellor of the University of Global Health Equity in Rwanda. She has held numerous high-level positions within the Rwandan government and had been one of the 100 most influential African women in recent past. So I have the great pleasure in inviting Dr. Agnes Binagwaho to give her deliberations and share her experience, how in Rwanda the colleagues have really dealt with the pandemic and particular use of data in dealing with this health hazard. Honorable Vice Chancellor, please.
First of all, thank you for having me. And I'm very pleased to be part of this really august assembly where experts are discussing an important topic. And I'm going to share the experience of my country, which using the principle of implementation science has managed to coordinate national COVID-19 vaccination strategic plan. And why I say using the principle of implementation science is because it is based on knowing your context, the positive one or those who are barriers, knowing the data is part of all steps, and also decided to use evidence-based intervention that has been proved by science and adapt the strategies to Rwanda. So, this is not by chance that we have successfully implemented the vaccine, COVID-19 vaccine in Rwanda, at least the vaccine we have, because you know the shortage we face globally with not enough vaccine on the market and the rich country who are holding a vaccine, but those we have implemented very well. The country, in fact, every time there is an introduction of a new vaccine, the Ministry of Health will complete a national logistic assessment of the cold chain when it's needed, like for some of the vaccine. So the assessment is done from the airport up to the point of delivery services, inoculation of the recipient of the vaccine, and this across the country. As an example, to show you that it's important beyond COVID-19 vaccine, we did the same for HPV vaccine. We did the same for any vaccine we have introduced since the last 20 years. So now let's go for the COVID-19 vaccine rollout. When vaccine, so early during the pandemic, when the world was racing to find a vaccine to save the populations, we start, and when we heard that some of the vaccine will need the temperature up to -70 degrees Celsius, Rwanda did the same. We assessed completely the logistics to deliver such a vaccine from the airport up to the place of inoculation. So what we did, first of all, we collect the scientific information of who should be vaccinated first because they have a risk to die if they are infected. So we had a priority list by hospital, collected by district. So we had data district by district, and they were collected at national level and monitored by the Prime Minister. So when we have the list of those who have to be vaccinated, we have the logistics that was assessed, the cold chain across the country. When the first vaccine landed in the airport, the same night they were tagged and they were dispatched in place for be delivered in each district. The morning, that means less than 8 hours after, there were car and truck because we bought trucks and fridge and car and transportable cold chain to dispatch the vaccine in all districts, taking in account the priority list given by each district. And we sent the vaccine there.
Madam,
yes?
Can I interrupt? What vaccine did you use?
Pfizer. That's what
Pfizer.
came.
Okay, please.
You know, we don't have, it's not bad, but I want to tell you that we take what is coming because all the vaccine are saving people. So it was Pfizer.
And they were commercially procured or they came under COVAX?
They both. They came under COVAX. They came under COVAX, the majority of them.
Yes, please proceed.
Okay, so so now we have the vaccine at the airport. We have in the morning cars, truck that has fridge that go in all the districts at the same time and arrive in all districts before 4 o'clock at night. For the districts that were far, the army gave the helicopter to bring the vaccine there. And the day after, in the morning at 9 o'clock, in all the country, all the people who were on priority list were vaccinated. That was the caregivers, community health workers, and people with underlying condition. And after that, other came. And the list was done up to now. It's open because all the people at risk have been vaccinated, those who are willing to, because there is no obligation to be vaccinated. But I want to say that hesitation is not really a problem in Rwanda because people trust the Ministry of Health. I want to interrupt
you once again. Sorry. That's a very fantastic overview about the process, how the procurement was done and the supply management was done, and then the delivery and the inoculation was implemented. Excellent experience. Can you really, I will have to, at this point, I will have to stop you and bring you back again and later when it comes. But I have one question to you. How all this process, has there been documented and empirical evidence, as you have said at the very beginning, evidence-based intervention? So can you really relate a couple of the evidences which you have collected and how they may be used in the future?
For us, I just say it's a vaccine among many. We have, let me tell you, 93% of our girls aged 12 to 21 vaccinated against HPV vaccine for prevention of cervical cancer. And we have 90% of our boys and girls vaccinate against 11 antigen. You see, so this is just another one for another type of population in the same district, using the same cold chain, the same principle of implementation. So in fact, that it was integrated in the national vaccination program and integrated in the national plan to fight COVID helped a lot. Integration, data, evidence.
Excellent, excellent. Thank you, madam. I think that's a very spectacular experience that the COVID vaccination was integrated in the national overall vaccination plan across the priority demographic cohorts and locational priorities in that sense. Thank you very much. Please don't go away. Please be with us and listen to others. And also you may come back as you feel free in the coming half an hour. Let me now bring in another. We have just heard Rwanda from Africa, low-income country, and another Bangladesh. And now I'll bring in a low-middle-income country. And to bring in the Bangladesh experience, we have here Anir Chaudhry. Anir Chaudhry is a policy advisor at a platform or an entity or an agency which is called A2I, Aspire to Innovate. It is a platform, the whole of government digital transformation platform. It had been behind the data drive for the vaccination during the COVID period and and giving digital support or data support to various ministries, and had been supported by the UNDP and the Gates Foundation and others. So I'm very happy to bring in Anir Chaudhry, who had been in the driving seat of these issues, and to share his experience over here. Anir, your 5 minutes.
Thank you, Chair. I think Honorable Vice Chancellor, Dr. Bina Guaho, actually made my job a little easier. Many of the same challenges. So resource constraints, knowing your priorities, knowing your context, logistics management with the number of vaccines that we received, then adverse event tracking after immunization, campaign to make sure that we go over vaccine hesitancy, and coordination across many agencies of the government, including the Ministry of Health, DG Health in particular, IDCL, which is our Epidemics Institute, Ministry of ICT, which I represent, and many other cabinet, which basically manages the entire field administration. So there was a huge coordination effort across the entire government and led by the Prime Minister's office to make prioritization happen. So I'll talk about a few things, and you told me 5 minutes, so I'll try to stick to that.
You will get to come back again once we get the decision.
Thank you.
Please.
Thank you, Chair. So the first is target group identification. So severity, case, fatality, looking at gender, age, comorbidity issues. So this actually gave us, and looking at our national ID database, this actually gave us a good identification of who we need to immunize. So that's the first thing that data really helped us. Second is use of national ID and civil registration. So we started with national ID because almost every adult in the country has a biometrically verified national ID, and we use that database that resides outside of the health system, but we use that database. We also use database from our Ministry of Finance, because a lot of our frontline workers, doctors, nurses, government officers, they were actually in the field, and they were the first beneficiaries of vaccines. And the payroll information, the payroll database from Ministry of Finance was a great help in actually targeting the right population. So the payroll database was used. Recently, as we are vaccinating our students, we are using the civil registration or the birth registration database from the Ministry of Local Government. So again, coordination across many different agencies of the government is coming into play. The online registration, as we saw in the online poll, that online registration actually helped in many countries. And even though Bangladesh is a country which started digitization only recently, I would say about 10 to 12 years ago, with our Honorable Prime Minister declaring 2021 as the digital Bangladesh year. So we really started about 12 years ago to build a digital country. And data became a very, very important aspect of that digitization process. So looking at our databases of different entities, I think really helped us. And the online registration process, although it started with a little bit of a hiccup, we felt that perhaps the marginalized who may not have access to the internet or apps, they would suffer and they may not actually be able to register. But what we did at that time was to leverage our 14,000 community clinics, which is a very important aspect of primary healthcare in Bangladesh, and about 4,500 what are called digital centers, which are the bridges between analog citizens and the digital world of service delivery. So the digital centers are run in local government institutions, about 4,500 of them in the rural areas, and they're run by entrepreneurs sitting in these local government institutions. And they actually helped the marginalized population register on this online platform, and the community clinics also helped that. We also had NGOs helping out in the registration process, as well as our national helpline called 333, where people would be able to call in and get help to get registered online. So these are some of the techniques that we used. In terms of inventory management, that's where data also helped us, cold chain management, management of the syringes, the vaccines themselves, the different lots, registration certificates, vaccine certificates. So again, data actually helped us generate the right documents and keep track of things. The last thing that I want to bring out is really how coordination was done and how, in terms of campaign, in terms of communication, how it was done. So actually, as I mentioned, several agencies of the government that worked together, but also we had the private sector and NGOs working together. We had a risk communication and community engagement team with about 40 plus agencies of the government, private sector, NGOs, development partners working together. Johns Hopkins was there, UNICEF was there, BRAC was there, along with the government partners. So we actually generated over 2,000 pieces of content, static, dynamic, audio, video, animation, and about 650 of them were actually had to do with vaccine registration, vaccine, getting over vaccine hesitancy. So that whole communication was also driven through data. And as we embarked on special campaigns to bring in people for vaccination, we went from 800 routine locations for vaccination to over 6,000 locations during those campaigns. So again, all this is driven by data dashboards. We have dashboards for vaccines, dashboards for disease progression across the entire country, dashboard for mask adoption and all of that.
And I just want to interrupt.
Sure.
You see, Dr. Agnes focused quite a lot on the procurement management.
Sure.
And there was a lack of predictability in terms of procurement. So, but you have focused more on the delivery and how identification on that. So how this, with this matching of the supply and the delivery is being done, how that process is to be coordinated from the data sense of the things. Is there any experience on that?
Sure. Our national ID database and the civil registration with the birth registration, which is a complete database, birth registration, and the national ID for the adults, biometrically verified. So that actually gave us a sense of how many we need to procure. And procurement went through some uncertainty in the beginning, obviously. So we started the vaccine drive, the major vaccine drive early February, and AstraZeneca was the vaccine of choice at that time, because that's what was being procured. We had other vaccines coming in later on. There was a period of maybe a month or so. There was uncertainty in terms of getting vaccines in the right numbers. Then we negotiated with various vaccine producers around the world. So we actually negotiated with China.
So the coordination issue is not only within the country, but it has to be also intergovernmental agencies, intragovernmental.
So there is vaccine
global
diplomacy.
Coordination.
Absolutely.
So that point I wanted to highlight.
Sure.
Please, you have 10 seconds more to close.
No, I'm good.
No, I give you 10 seconds, please.
Thank you. Okay. Thank you very much for that. So vaccine diplomacy was actually a very important part of the whole thing, where our Ministry of Health and our Ministry of Foreign Affairs worked very closely together, guided by the Prime Minister's office, because we had to negotiate with various producers, and we had to, in a sense, compete with other countries who also needed vaccines, right?
No, thank you. That's coming out very well. I think we heard, Anir, from how the data sources, the national data sources played a critical role, and also the partnership with the non-government actors as well as the private sector has been quite critical in these cases. And the data issue does not end after inoculation, but also the certification management is also a major issue, as we all know. And those who have traveled to Bern, they know that how important the health certification is important for all of us. Let me go to my third panelist. And now moving from Africa to Asia, let me go to Latin America. And a country of great repute, Argentina, is here with us. And my good friend and colleague, Natalia Aquilino, is here with us. She is a program director for evaluation and assessment at the CIPEC, is one of the leading think tanks in Latin America and Argentina in particular. She also teaches evaluation at the National University of Argentina. So I'm so happy to see you over here, Natalia. So how did it all go in Latin America? We hear various kinds of stories, ups and downs. So let us hear it from the horse's mouth, please.
Thank you so much for having us and inviting CIPEC to this very important meeting. And hello to my colleagues here. I'm enjoying and learning a lot this morning with you here. I would like to focus on three things. Maybe one is the context of the data context in our country. The second is to identify some best practices that may be of help. And finally, the recommendations that we are providing to our government here in Argentina from our think tank CPEC. The first one is that some characteristics of data that framed the vaccination strategy are very important. The first one is that COVID-19 information was highly demanded around our country by citizens, from governments. Everyone was looking at COVID-19 data, and this put under the spotlight the quality of the data that was being published and the relevance as well of the quality and the importance of having open data portals, having share information about this. The second one is that at least in our country, the main characteristic of the data for decision making is heterogeneity. We have data quality, and we understand data quality by being delivered in accessible portals in a timely manner with standardized disaggregation structures and in a reusable format. We think and we believe that this is crucial for government transparency, for vertical accountability with citizenship, and to improve decision making. But not all the time we did find this quality across the country and across the data structures for COVID-19 and also for the vaccination strategy. And finally, in terms of context, Argentina had a second level problem, which is that we are a federal country. So there's a lot of diversity in terms of quality at the subnational level as well. So for instance, 6 out of 12 provinces publish pandemic data, reports or dashboards, as my colleague was saying, on their health or government pages, but some of them still uses communication channels to share information that is not reusable, not accessible. So we do have a lag there in terms of quality. Also, we find out in a comparative study that we just produced and presented last week, comparing Mexico, Brazil, and Canada, all federal states in our continent, that there's low accessibility. You need to navigate through different portals to understand the entire situation in terms of COVID-19 and in terms of vaccination strategy as well. There's also a lot of differences and big differences on what data is reported. Sometimes information can be disaggregated by number of doses, how many were received and applied, type of vaccines, percentage of population groups covered, but any combination of those data types are also possible, and we lack of standardization. And finally, data uploads is worse than COVID-19 reports. We find out that this is a big important differences, and finally, reusability is very low still. Only the cities of Buenos Aires and the province of Jujuy is publishing data sets on open formats. So what we learned from this, I would like to frame 3 best practices that we think are important, at least in our context. The first one is that our governments took advantage from COVID-19 sanitary data. So this, when vaccination strategies started, each government had already had time to develop, improve the process to capture, systematize, and publish information. So this was like an advantage when we started with the vaccination campaign. The second best practice that we might find, at least in our countries, is that having a strategic vaccination plan against COVID-19, well-informed, well-planned, open to the public, that includes some monitoring, oversight, and evaluation components, gave a lot of structure to the data that was published in terms of the vaccination plan. And this also increased trust while addressing one transparency issue that we did have in our country, and I know in other Latin American countries, that put the vaccines administration under the spotlight. And I think this gave a lot of more clarity and increased transparency. And finally, the third best practice is that some governments, some subnational level governments, though not on national level, implemented some software, some open source software and solutions that provide unified and secure data exchange between organizations, increasing, in these days, interoperability. They implemented X-Road, which I think is a very well-known one, to try to gather and put in place all common information. So what are we recommended in terms of policy-driven actions to be taken? Only 5, and I will finish with this. The first one is to enhance regional, federal, and subnational collaboration frameworks in terms of standardizing, sharing, and publishing public information. We recommend to develop a vertical coordination strategies between the federal government and the subnational government, as my colleague just referred to, and in a horizontal manner as well between the different federal agencies, which is key to develop an effective vaccination strategy plan. The second one is that we need to have a federal open data policy that allows balancing the capacities of the subnational to produce and systematize data to the national regulatory frameworks. I think addressing each state's limitations is crucial for us, at least on allowing those national, regional, or international standards on open data mentioned above to be reached by all states in Argentina. Third, we think we need to develop a national COVID-19 open government data monitoring and evaluation framework in order to evaluate effectiveness, efficiency, and adaptation to regulatory frameworks regarding personal data, cybersecurity, and openness, which are crucial to our context. In the fourth place, we also think that we need to adopt and or adapt international open government data standards, such as the one proposed by the Open Data Charter under the disease surveillance component, which provides detailed information on the published data in every website and every piece of information in every public space that delivers information on this. And finally, to us, disaggregation standards is the key these days. It's fundamental to allow interoperability, which means that data could be combined with other data sources to create new knowledge, whether by citizens, organizations, or adding or improving standardization of quality data related to health, economic, and the pandemic as a whole, which can dialogue with each other, will allow to more in-depth, multivariable analysis and more informed decisions, which is the keystone to coordinating
policy suggestions, and your emphasis on the challenges of a federal country is very well taken. And you end with the disaggregation issue and the interoperability issues. Those are all taken. I just give you 15 seconds to respond to one question. Given the fact that this kind of data initiatives were undertaken in Argentina, how do you compare the success of Argentina in terms of combating the pandemic vis-a-vis other countries, not Brazil, other countries? Other than Brazil,
I think we're
would you consider how successful you had been in use of data?
I think we're in the middle of the table. To us, all the pandemic was a trigger to at least start discussing how data is structured, how data is produced, and how we can take the best advantage from this context. So I think we're in the middle of the table.
Okay, thank you very much for that very candid response. Dear participants, colleagues, I will now bring in the fourth, but definitely one of the most important presentation which I have been waiting for this panel. And we now go to United States of America, to New York. And with us, we have Mr. Terry Paris Jr. He is a very eminent journalist who had been part of the finalists of the Pulitzer Journalist Award in 2017. He had been nominated for many other prizes, and he had been a very socially active journalist who had been with the City and a newspaper, now moving to New York Times. Had done studies on the left behind people, the black people in United States, and he is here with us to share his experience. Mr. Terry Paris Jr., please, your 5 minutes.
Thank you so much. I definitely feel like the odd one out here as not a data scientist or an expert on policy. And I'm really just an editor and journalist. So I'll speak from that lens, and being an editor and journalist in New York, sort of how we experienced and saw the pandemic unfold from the height of it to vaccinations. So I'm on this panel due to a project that I started with my colleagues, Anjali Choi and Derek Kravitz, called Missing Them. It's a collaborative journalism project and crowdsourcing project with the Columbia School of Journalism, Brown Institute for Media Innovation, and the New York-based nonprofit that I was at called The City. And it started as a sort of a data journalism project. We wanted to understand who was dying due to COVID at the height of the pandemic. And that data was incredibly scarce for us to find as journalists. There wasn't very much. Medical examiners weren't releasing anything. And so we turned to public records or public obituaries. And to our surprise, not to really our surprise, but that really skewed white and male and to the wealthier enclaves of the city of New York, which didn't reflect exactly how the virus was affecting everybody, which oftentimes were immigrant communities, Black and brown communities, essential workers, things like that. So our project, using crowdsourcing, community engagement, and community organizing, created a digital memorial and a series of accountability reports that helped close that gap of representation of who was remembered and who wasn't. While our sample size was small, that work more closely resembles how the virus impacted on the ground. Those issues that we saw in that beginning of the project and collecting data and trying to understand what happened were some of the same issues that we saw in the rollout of our city's vaccination strategy. There was a lack of data, or it was cumbersome, or it was hard to access, and there were a lot of equity issues. There were a lot of dashboards and data shared. It was sort of like, there was a lot of openness, but it was really hard for people who needed it most to actually access it. So much like, some other countries, those who needed to access it first were the elderly, hospital workers, immunocompromised, teachers, but it was cumbersome. Folks could not sort of navigate these websites. And in the beginning, those who needed it were, may not have had the digital access, the digital divide and things like that. And for example, in one of the sites that was delivering the vaccination, they had no Spanish speakers in a predominantly Spanish speaking neighborhood. So in fact, one of our reporters had to put on her translator hat and work with those to navigate that site itself. And this is where it was really interesting to see what happened in lack of this sort of more ubiquitous and accessible data, is that community-based organizations, local technologists, journalism organizations like ourselves started to fill in those gaps. So folks who had trouble finding a site, for example, local technologists built sites that aggregated all those available appointments in real time to make it easier for people to schedule appointments. Many communities were also untrusting or confused about how to access the vaccine. And if they were eligible or maybe were too afraid to leave their homes, this confusion was predominantly in immigrant communities and in particular in the Asian communities. So community-based organizations sort of hit the ground, taking a more hands-on approach to get the word out, including tabling at churches, knocking on doors, helping community members individually sign up for vaccines, tens of thousands of individuals. And New York is a big place, as we all know. But flash forward to today, there's government mandates. You have to show a vaccine card to go into places. There are outreach programs and incentives. If you get a vaccine, you're available for a $100 gift card. And so the vaccine is very available. It's in all major drugstore chains, and it's free. And in New York City right now, over 70% of those in the city are vaccinated, almost 6 million people. Yet there are lots of struggles still, ultimately around trust. In some of the areas that are more vaccinated, and some of our areas are obviously more vaccinated than others. And it's been harder to reach young folks. It's been harder to reach the Black communities in particular throughout the 5 boroughs. And so that deeper sort of, that issue of confusing rollout and digital divide and strategy has now sort of focused on the ability to trust the vaccine. And so some of the things that we're...
May I interrupt you to one thing? So was there vaccine resistance? And did your initiative play any role over there? Because we have seen vaccine resistance or denial or lots of things over there, both in terms of denying the pandemic and also the trust on the vaccine. So how your initiative really dealt with that issue would be interesting to know.
So yeah, I mean, there's one of the things that... So there, in particular, in the Asian American community here in New York, in Chinatown or in Queens, where there's a large Korean and Chinese American population, what ended up happening is local community-based organizations that serve these communities took what was available from the city and actually went into those neighborhoods, held registration drives, helped elderly sign up for the vaccine and navigate that website. So it all became a very grassroots effort in many of these communities from those trusted and local organizations to get tens of thousands of folks in the areas to register for the vaccine.
And you updated those data every day. Is there a repository of that data and how it is going to be interfacing with the public data system?
So for those community organizations, we're not sure if they've logged every single one of those. What we do know is that for some journalism organizations, one of them in particular called Epicenter has logged the number of folks who they have registered, but it's not updated daily. So it's not as structured and organized as it should be to see who's been registered and who's not. And it's really just has been this grassroots effort.
Okay. Thank you very much, Ms. Paris. I think you have put a human face to our discussion and brought it closer to the life. And definitely it's very, very refreshing to know the community initiative which takes this kind of issue to the doorsteps of the real people in certain ways. And good luck to you with your new things and other things. Please don't go away. Maybe queries on behalf of the participants, colleagues, participants, friends. We have at this moment, let me recognize the 23 people who are in this room, which is a big gathering given the World Data Forum going on, parallel sessions across this big building. So thank you very much for joining us, those who are in person with us today over here. We have on Huvoha, how do you pronounce that? Huva. We have 43 participants on that line, and the Zoom we have 32. So we have at this moment more than 100 people listening to you. I think that's a great achievement in many ways. Thank you very much. I will now open up the floor. You have just heard 4 colleagues from 4 different continents, and you have also heard my colleague the summary results of the survey, which is very much on and it is the new online results which we are getting are also very much close to that what we have shared with you at the very beginning of the session. So I'm now opening up the floor for the next 10 minutes to see if colleagues, if you have queries, if you have comments, if you have observations, anything else, we'll be very happy to take you on board. You are online, but please keep it within as less than a minute will be much appreciated. And new issues, if you raise new issues, any new supplements will be much, much welcome. The floor is open now. And those who are in the Zoom and others and will be also be invited to put in. So let me recognize first Dr. Flora, Dr. Mirzadeh. She is from the Ministry of Health from the government of Bangladesh. She had been the public face of the COVID pandemic, reporting the number of deaths and infections every day on national television, and is a scientist of her own repute. Please.
Thank you very much. I not only reported the cases and deaths, but as well as shared what to do to contain the pandemic. So the public health and social measures. Actually, as Mr. Anir Choudhury has mentioned about our vaccination strategy, and also I'm leading the vaccination activity, vaccine deployment core committee in Bangladesh. Therefore, I would like to add some more insights in the discussion. As the Honorable Vice Chancellor mentioned about National Vaccine Deployment Strategy, so we also developed a National Vaccine Deployment Plan at the beginning, and which is actually a living document. It has been changed as per the requirement later on. Initially, we targeted the high-risk population to vaccinate, which means those who are high risk to be infected and those who are high risk to be fatal. So these two groups are targeted initially at the beginning. But as I mentioned, it's a living document. So later on, we focused on the economically important aspect also. Therefore, currently our priority group includes the migrant workers and also the students, because now we are at the phase of reopening our academic institutions. So I wanted to mention that the flexibility we have in planning the vaccination and also accommodating the need of the country. Secondly, the issue I wanted to add on regarding the data generation, not only for the planning purpose, and also as Mr. Anuchaudhuri mentioned about the vaccine certificate, but we are now continuing with the post-vaccination surveillance also. So data are being generated there, and also the pharmacovigilance data. Those are actually really important. As you know that in Bangladesh, you are using different kinds of vaccines. Size-wise, Bangladesh is a small country, but population-wise, it's a large country. Therefore, to accommodate or to manage the vaccine requirement, we are procuring different kind of vaccine. Therefore, this post-vaccine surveillance and as well as the pharmacovigilance is very much important. Thank you for giving me the opportunity. Probably I was within 1 minute.
I think those are very good supplements. Thank you very much. I think two new issues over here, at least two new issues I pick up for my own summary. One is that a number of countries are using different types of vaccines. They do not sticking to one particular. So how do you mix and match, and how do you deal with that? And that brings you to the second issue, that post-vaccine surveillance is another new part of the data generation and also in terms of keeping the record straight in these cases. Thank you very much, Dr. Flora. Anybody else, please? I have lots of fellow countrymen speaking here. Please don't consider that I am being partial as a moderator. It's just that the hands I have at this moment observing. Please carry on.
My name is Alamgir Hossain. I'm from Bangladesh Bureau of Statistics from the same country. My question is to Mr. Anuchaudhuri, that you have mentioned about the database you have used for managing
Let me stop you over there. Don't ask questions. Let me ask you a question. Sure. What did the National Statistical Agency do in the case of COVID? What is their contribution?
Yeah,
NSOs, National Statistical Organization.
Okay, thank you for the question.
Because he won't get a chance to respond. Please,
okay.
you share it with us. Please carry on.
Okay. Regarding the vaccination, we actually provided some aggregated data to the decision makers regarding the different demographic aspects. And for the economic aspect, we have provided behind the statistics for the decision-making process. Even we have conducted few surveys of our phone, and we provided, especially on the economic and socio-economic issues. And another issues was the risk transmission of COVID issues as addressed in this aspect. And actually, we are completely involved some of our activities regarding the social safety net coverages. We have provided some data supported to our subnational level, the district administrator who are actually involved in the process of building the databases for.
So, what one new thing which National Statistical Organization should do, taking cue from the COVID experience? One new thing.
The strategy or modality of data collection and compilation is very important to us. So we have to think of the new modality, how to data collect, compile, and disseminate.
Okay, thank you very much. Thank you very much for the inputs. I appreciate that. Anybody else from the room? There is at the end of, please, Miss.
I was scared to raise my hand because I was scared that you're going to ask me a question.
Take off your mask. We won't get contaminated.
No problem. Is this better?
Yes, please. Please introduce yourself.
My name is Rusita, and I co-lead a data analytics firm. This conversation is important because data is important to be able to respond properly to the COVID pandemic. I'm just wondering, your countries, your organizations, what are we doing to make sure that we also measure the impact of COVID on essential health service deliveries? How do we know and can act to prevent more child pregnancies, to prevent more, let's say, calamities happening on other fronts that have been neglected due to COVID? How is data playing a role there?
I think that was a fantastic question. I think very, very perceptive question. Can I come back to that? And I would personally like to respond to that from our experience and our own research and analysis to that. The impact issue. Short, medium, horizontal, vertical dimension, intensity. I will come to that. Anybody else from the room? If not, let me read a couple of comments which are coming into the chat box, please. Would you kindly read it for me?
Hello. Okay, so there is one question that came from, do you agree that if implementation of vaccination happened to granular level, real time, in terms of reporting, better than collective reporting. There is another comment from Gema Wood. She said, have people found good ways to reach vulnerable groups? Is there a place where culturally and language appropriate pushes for vaccines have worked, and how can we share them across countries? I have another comment from Mazbaul Ahmed. He said that a few concerns related to data-driven decision-making at a policy level, the quality of data, if incomplete or biased. Number 2, the decision-making process, if not inclusive and rigorous. And 3, policy analysts and stakeholders of the decision-making process, if not multidisciplinary. And number 4, outside influencers, mostly political and administrative. I have another question from Mohammad Shaidi Abdul Rais. He said, hello speakers, what is the completed COVID-19 vaccination rate in your country, and how well data-driven strategies helping the vaccination outreach in rural or remote areas? There is another comment from Kashmira. She said that there is a problem in our country. I don't know her country, but said there are enough vaccines and guaranteed access, but less than 50% of citizens want to be vaccinated due to negative public attitudes and distrust on vaccine. These are some of the questions.
Thank you very much.
But we have some hands.
I will go to our Zoom participants over here. I see number of hands gone up. I cannot read the names.
Mahbub Shaheen from Planning Ministry, Bangladesh.
From the Planning Ministry, Bangladesh, a government official, Mr. Mahbub Shaheen. Please, you have your minute.
Yes, thank you for giving me a chance to ask a few questions. First of all, I would like to ask Mr. Anil Choudhury regarding the...
Mahbub, anyway, I won't be able to take you question answers over here. Share your opinion and observation. That will be nice.
Okay, fine. Very good. So my opinion is to introduce the second time COVID attack after after taking the vaccination. How do you data preserve after vaccination the second time COVID positive or COVID chance, so COVID infection? Yes.
Okay.
Please.
So that's a very important point. We discussed sometimes back this one, that how do you really keep record of the repeat testing, and how do you relate it to the vaccination and thereafter? Thank you very much. That question. Second, who else is there?
Professor Mustafiz.
Professor Mustafiz, I see. Please, you have your minute. Mustafiz?
Can you unmute?
Can you? We cannot see you.
Okay.
Let me.
Thank you, Chair.
There you are. Mm-hmm.
Yeah. Thank you, Chair. My suggestion is that since at the moment we are now only covering about 15-20% of the people, and people are rushing, we don't know what is the percentage that that will demonstrate vaccine denial. So I think that we should have some early idea, so that as we progress, we have some idea with regard to people who will need to be convinced to be vaccinated. I didn't see any data on those who, what is the percentage who will not be willing to be vaccinated.
So your question is that how do you really get an idea about the magnitude of the share of people or share of population who are in the denial syndrome, and how do you really manage them? Thank you. And how data can play a role in this case. Thank you very much. Who else is there raising hands? I can see a number of hands over there. 1, 2, 3. Please carry on. Please.
Saeed Hassan Imtiaz.
Saeed Hassan Imtiaz, please. You have your
hello,
minute.
Hello, I'm from
yourself,
for Public Health. My observation is we have a problem with digital literacy, and we have seen that many people not register or got difficulties in getting them registered in the national vaccination campaign. So we should get some digital literacy problem-solving skills or digital literacy-related education schemes into the high school or college level so that everyone can.
Well taken. The point is well taken. Since online registration and other things and the data is digitalized so fast that we need to introduce the digital literacy programs much more at an early stage in the schools. Thank you very much. Who else is there?
There is Kazi Ami and Professor Agnes.
Ami, would you come on board now?
Yeah. Thank you for giving me the opportunity,
yourself.
Chair. Yeah, I'm Kaji Rabia Amy, and I'm working with Oxfam in Bangladesh. So my opinion is there? Would it carry any value involving the local level organizations, or the non-government organizations or the community-based organizations in the vaccination awareness raising or the registration process? If government can involve them in the awareness raising or registration process.
Yes. If you have listened to Natalia, you have heard that how the subnational level organization and the partnership was all important. Anir also emphasized the role of the national NGOs and etc. Excellent. That way we have, I have 5 minutes left. I will close that. Anybody else for 10 seconds? That's the last hand I see.
Can I say something, Agnes? Agnes Binagwa.
Madam, I will bring you in now to give all the 4 panelists to make their closing statements. And I will forego my time to give you the space. So let me start from the backward. Mr. Terry Paris, any last parting thought?
I think such a big part of getting folks vaccinated, at least now, is figuring out a way to build trust with them, build connections with them, particularly for New York, which we're at nearly 71% vaccinated. So that will be a huge push for us in this city, whether we're journalists or data scientists or building things, is figuring out how to connect with people and get them to trust the information that's out there.
Thank you very much. Thank you for that thought. Let me go to my colleague in Argentina now, Natalia.
Thank you, Deb. I totally agree with what was said by Terry. I think trust is key to transparency and to have people integrated and supervising and overseeing vaccination strategies implemented in the world. And just to last remark, we do have more than 50% of the population already vaccinated with 2 doses. So I think it's not candid to say we are in the middle of the table and performing as a middle-income country. What we are. Thank you, Deb.
Thank you, Natalia, for that. Also giving the share of the population vaccinated. Anir, I'm sorry I didn't give you the chance to respond, to take over the rest of the session, but you can have your minute now to do that.
Sure. Thank you, Chair. I'll talk about it. There are a lot of questions raised from Bangladesh, obviously, but I won't have time to go over all of them, but maybe 2 or 3. I think the repeat COVID attack, that's an important issue. What we did in Bangladesh is we established a dedicated telehealth service for COVID patients. So what would happen is the PCR tests would go to the telehealth service, and they would actually would call the patients and would follow them up for 2 weeks. And then they would provide support, medical advice, even psychological support, hospitalization support, and all of that. What we're doing is, since that database is very well structured, we're going back and actually finding out how much of the reinfection actually happened. And in cases where even after vaccination. So that data, that telemedicine data, it's a very deep wealth of information right now to conduct that kind of research. So combining with that kind of data, I would like to address one question, Chair, you asked about the role of NSO. COVID has taught us that we need to distinguish between statistics and data. So when we talk about statistics, national statistics, and NSO is the designated organization. When we talk about data, it's really everybody's business. Everybody meaning all agencies in the government, private sector, NGOs. So I think everybody's collecting data in their own way. Perhaps NSO can provide guidance, but if you then say that NSO has to do the data collection for everything, that's absolutely not possible. And also, I think a very important thing that Natalia pointed out is interoperability. If we now tell the NSO that you establish interoperability, you establish the standards, again, that's not going to happen. So I think we need to work together to establish data collection methods of different kinds, innovative ones. We need to understand how data will be visualized for policymakers, because the traditional way of visualization is not going to work, and establishment of interoperability. I think these are very important points that we need to have. And I need to take 10 seconds on the digital literacy issue. Because digital literacy is a problem in many developing countries, including Bangladesh. That's why we actually created intermediaries. I talked about the digital centers, 4,500 in the rural areas, who actually support citizens who cannot get online, who cannot actually register themselves, so they support them. Also, the 14,000 community clinics are equipped to doing that kind of digital support. So they become the bridge between the analog citizens and the digital world of service delivery. So I think that's a winning combination we had in Bangladesh. Thank you.
Thank you. Thank you. Thank you very much for addressing those issues. Now to come to Dr. Agnes. Thank you for staying with us for the whole session, and you have heard that. I now invite you to give your closing statement. Madam.
So my closing statement is not going to be about COVID. It's going to be about health system. And saying that if we have a resilient health system, those data collection is on day-to-day basis. The patient-centered need and solution is on the day-to-day basis according to the problem and the science of today. So if you build an army during a crisis, don't believe you will win the war. So win the war, create resilient health system, have a good HMIS, have interoperable system that are ready to tackle health threat like it is. So that's my thing. And we as scientists, we should stop verticalize the health sector. Health information system is key in management of the health sector. So it's not something that we create for COVID. We maybe add a framework, but not create it. So it has to be created on day-to-day basis, patient-centered, decentralized, managed centrally as well, and linked to the procurement and to the activity we do. So bye-bye, it was great to be with you.
No, madam, I think so. You have given the right tone to this whole discussion, that it is not about pandemic COVID per se. It is possibly
absolute vital point, Shirin.
I think as spoken like a right policymaker, a leader in the thought process, that it is not about the pandemic itself, but how we relate it to our national health system, national information system. That is the key to this. Colleagues, I want to end here since the time has run out and make basically 3 or 4 points here. The first and foremost point which has come through, that the pandemic has definitely created not only a challenge, but also a great opportunity of using the data system for bringing in more transparency, more accountability, more effective national health system. I think we should take hold of this opportunity, grab it, and run with it. That's what I think. In terms of running with it, I think what came out first is how the whole the procurement system of the procurement system of the vaccines, the cold chain management, and coming down to bring into the grassroots, and how the data has played in a day-to-day basis role has been brought out by all the panelists over here, and as well as the questions coming from the floor have further elucidated those issues. I think the second point which has also come out is that once the management part is taken care of, the identification and also the inoculation and the post-vaccine surveillance, this part, here also data has played a big role, and we will have to carry on with that for some time to come. What has come around is the prerequisites for the successful data initiatives are that you need to have a national system. You have the national governments and their ability to coordinate amongst themselves and to use and share and the internal system along with that. Along with that came the issue of partnership with the non-state actors, the NGOs, the CBOs, and also the private sector. I wish we discussed more about the role of the public representatives over here. Within the data system, I think the need for a new framework, the new partnership, new rules of the business, and which we did not discuss so much today, is the issue of privacy and security of the data issues. All needs to be put into place in order to look into the future as we go. And the issue which was there in the impact, let me come to that and address that. If we have managed the issue of procurement, if we have managed the issue of vaccination and over there, what is important now for us is to use this data to assess the impact of this pandemic on the economy, on the society, on the environment, and on the governance. And to do that, we need to understand how the impact or the effect of these pandemics are becoming visible immediately, and some may take some time to be visible. For example, on the environment. What is also important to understand how the intensity of this pandemic will play out in different sectors of the economy, starting from the exports to investment to our employment issues, how it will play out in different sectors of the different social cohorts and communities and groups, on women, on children, people who are left behind for different reasons, because of civil identity or remoteness of location, and physically challenged people in the senior citizens. These are all these things impact. We will have to look into this. And we will also have to look into how we are going to address these issues with different kinds of public policy interventions, where we will be able to use this data in order to have a much more effective national recovery strategy, where the vaccination will be a part of it. But no less important is to bringing out a robust national health system which looks at the people and its people, particularly those who are left behind, and provides the national level security, social security, national, local, the minimum income, and many other issues along with social protection. So the colleagues, friends and partners, what I wanted to say today, let us take this COVID issue as an opportunity to redesign our own national health system, if not our social security system, so that anymore that kind of pandemic in the future cannot really create this much of havoc, particularly on our left behind and disadvantaged people. Thank you very much for this attention, and I'm very, very grateful to all of you for being here today. And we will take forward these ideas which you have given us, and I'm sure the global community will as well take up some of the thoughts which you have shared with us today. Have a good evening, good afternoon, or a very good day. Thank you.
Thank you. You too. Thank you so much. So nice session.